inrolled border of the aponeurosis of the external oblique. All right, and you can see now it's gutter shaped, and it's going to be containing the spermatic cord. Okay, so see the spermatic cord in here? In the female, it's going to contain the round ligament of the uterus. Right, now the spermatic cord, as you can see, is quite a complex structure here with a number of things and all sorts of coverings. But the main constituent is the vas deferens that's going to be carrying spermatozoa from the epididymis to the ejaculatory duct. Okay, all right. So as you see here now, its edge that is we should say enrolled or rolled inwards to form a gutter. Okay, all right. All right. Now, also, we can point out here that the lateral part of the inguinal ligament, remember, has some muscles attached to it. We said in the last lecture that the internal oblique will arise from the lateral 2/3 of the inguinal ligament, and the transversus abdominis from the lateral 1/3. So there we see this gutter-like structure. So if we were to trace it and go further up and more laterally, by the way, that's a deep inguinal ring. Very nice. And we can see the vas deferens and all those structures entering. And then we will see that medial to the deep ring is the inferior epigastric artery. So that inferior epigastric artery ascends along the medial border of the deep ring. All right, this is a beautiful picture here. So I put in this picture here and blew it up. All right, so this is a great picture. The only error, so this is a nice thing for you to print, but you must just point out on this thing that this is an error in that they have this as if it is muscular. It's not muscular. This is all aponeurotic. Okay, this is all aponeurotic right here. Okay. So what you're looking at is a sagittal section, through the inguinal canal. Okay, remember the inguinal canal now is about 4 centimeters long, right? And there you can see it commencing at the deep ring. remember, I tried to cut that little thing, that tube, to show you that there's a deep ring with a circular defect. So this is a transversalis fascia, and there's that circular opening, which is referred to as a deep inguinal ring. We should know a couple, I just digress again, just to know a couple measurements and some points, that at the mid-inguinal point, the external iliac artery will become the femoral artery. At the mid-inguinal point. Now, what exactly, any of you students can tell me what is the mid-inguinal point? Can any of you tell me what the mid-inguinal point is? Remember, I can't see any writing, no chat thing. You have to talk to me. Students, are you there?
So it's the point between symphysis and the ASIS? The pubic symphysis.
No, go ahead. No, what is the mid-inguinal point?
Is it the point between the ASIS and the pubic symphysis?
Perfect. Very good. So the mid-inguinal point is the midpoint between the ASIS and the upper border of the pubic symphysis. Whereas the midpoint of the inguinal ligament is the midpoint between the ASIS and the pubic tubercle. Okay? The ASIS and the pubic tubercle. Let me just go back. Give a chance. Just relax. One more. Okay, beautiful. Okay. So this is very important to appreciate this. So let's go now. The mid-inguinal point is the midpoint between the ASIS and the upper border of the pubic symphysis. And it is at the midpoint, the mid-inguinal point, that the external iliac artery will become the femoral artery. Now, the midpoint of the inguinal ligament is lateral to that. That's the midpoint between the ASIS and the pubic tubercle. Okay? We can see it will be lateral. I'm going to try and see if I can do another lab with you, and I'll make drawings there to show you. So the importance now of the midpoint of the inguinal ligament is that at about 1.5 centimeters above the midpoint of the inguinal ligament, which is lateral to the mid-inguinal point, you're going to find the deep inguinal ring. So let me repeat that the deep inguinal ring is about 1.5 centimeters above the midpoint of the inguinal ligament, right? The mid-inguinal point, which is medial to that, is where the external artery, iliac artery, will become the femoral artery. So there's a lot of significance to that, and a little later we'll encounter some of that significance. Okay, let's relax. Okay, so this is a beautiful diagram here. So remember, this is 1.5 centimeters above the midpoint of the inguinal ligament. And we can see that more medial to this now is the mid-inguinal point. And at the mid-inguinal point, the external iliac becomes the femoral, and then the external iliac is going to give rise to the inferior epigastric artery. So this is super important, right? And especially when you go to the hospital and all that sort of stuff and all the clinical things, because they're going to ask you now how to differentiate between a direct hernia and an indirect hernia, okay? And you'll hear some of your clinicians saying, well, if the swelling is medial, or is it lateral to the inferior epigastric artery? Okay? All right. So the inferior epigastric artery comes off at the mid-inguinal point, right where the external iliac artery, just before it becomes the femoral, and then ascends up on the anterior abdominal wall. And what do we notice? It is a medial relation to the deep ring. The inferior epigastric artery is a medial relation to the deep ring, okay? So if a hernia goes through the deep inguinal ring, that's going to be an indirect hernia, of which some of them may be congenital if they're appearing as in a child, okay? Little baby especially. If the hernia occurs medial to the inferior epigastric vessels, then that's going to be a direct hernia, okay? Then that's going to be a direct inguinal hernia. So if the protrusion occurs right here, as we saw in a couple of those slides, medial to that point. So remember, the mid-inguinal point is very important, okay? And you want, it's at the mid-inguinal point. So if there's a swelling, if there's a swelling on the patient in that area now, we're going to have to reduce the swelling, reduce it, press it, it will go back in, all right? And then we're going to put our finger at the mid-inguinal point. And then we're going to ask the patient to cough or to strain. And when they cough or strain, we're going to see whether the swelling is going to occur medial to your finger or lateral to your finger, okay? So when you put your finger at the mid-inguinal point, sorry, the midpoint of the inguinal ligament, the mid-inguinal point, you're right where the inferior epigastric artery is coming up, okay? So if it's medial to it, the swelling comes up medial to it, then that's a direct hernia, okay? If it's lateral to it, it's an indirect hernia, okay? All right, so students, are you following me? Greetings, Donald, how are you? Thanks, man. You all right? Not bad, not bad. All right, so students, as I said, this is a very good diagram here. Okay, so you appreciate what is happening in this diagram. This could not be any better. Okay, the only thing is that this should really be all what? Aponeurosis. Okay, next slide. All right, so this is a more three-dimensional and a nice representation of the inguinal canal. So it's as if you're looking through anteriorly here. You're looking through anterior. And you see that that inguinal canal, which is one of the focuses of our lecture this morning, that inguinal canal, how do we define it? What exactly is the inguinal canal? Would any of you like to venture to say, make a definition of the inguinal canal? Would anybody like to construct a definition of the inguinal canal? Any of you? Students? Would any of you like to try to define what the inguinal canal is? But I don't hear anything. So the inguinal canal is an oblique cleft, an oblique intramuscular cleft in the lower part of the anterior abdominal wall, commencing at the deep inguinal ring, which is an opening in the transversalis fascia, and ending at the superficial inguinal ring, which is an opening in the aponeurosis of the external oblique. So the inguinal canal, which is where the testis is going to descend through, that's how we started this morning lecture by saying, why do we have an inguinal canal? We have an inguinal canal as we have to provide a space, a passageway through which the testis can descend from the abdominal cavity into the scrotum. Why? Because, as I said, for spermatogenesis to optimally occur, it has to go and descend into the scrotum. We also said that there's an exact chronology of descent, okay? So the inguinal canal, what is it? It is an oblique cleft, an oblique intramuscular cleft, where in the lower part of the anterior abdominal wall, commencing at the deep inguinal ring, which I said now is an opening, but I'm going to use a more anatomical term, which is a defect, in the transversalis fascia, okay, and ends at the superficial inguinal ring, which is a triangular opening in the aponeurosis of the external oblique. The canal is directed IMF, inferiorly, medially, and forwards. The canal is directed inferiorly, medially, and forwards. Length of the canal is 4 centimeters long, not 4 inches MCQ, but 4 centimeters long, transmitting in the male, the spermatic cord, and transmitting in the female, the round ligament of the uterus. Now, that round ligament of the uterus, if we trace it up, will go right and connect to a part that is at the junction of the fallopian tube with the body of the uterus. So where the fallopian tube meets the body of the uterus, that's where this is. And say this were a female, and this is a round ligament. The round ligament is really analogous to the gubernaculum testis in the male. So remember, there's this cord-like structure. Think of you pulling a rope. You're pulling a rope and pulling along. So what is happening is that gubernaculum testis is involved in the pull of the testis, pulling it first to the deep ring, then from the deep ring through the canal to the superficial ring, and then finally down into the scrotum. In the female, it's represented now by the round ligament of the uterus, and that round ligament of the uterus will go and attach right to the junction of the body of the uterus with the fallopian tubule and continue as the ovarian ligament. So the gubernaculum testis in the female is represented by 2 things. 1, the ovarian ligament, and 2, the round ligament. And remember, the round ligament is going to insert into the skin of the labia majora. So when you look at the female, right? So very interesting with the embryology. When you do the embryology of the genital, when you do the embryology of the genital system, here's my cursor. When you do the embryology of the genital system, in the female, what we see as the labia majora is basically what we see in the male as the scrotum. Okay? So what we find out is that in that little early stage of development, they're what are called labio-scrotal swellings. Labio-scrotal swellings. Okay? In the male, under the influence of the hormones, etc., in the male, it's going to be directed to form a more saccular structure, which is called the scrotum. And in the female, we're going to get the labia majora. So the labia majora and the scrotum are homologous structures. Okay, the only thing that's basically different is the fact that in the male now, that cord-like structure will pull the testis down into that swelling. Okay, now very interesting what can happen in the female. In the female, some strange things can happen, but we won't go into that right now. Now see here, the spermatic cord enters the inguinal canal. Let's continue the definition of the inguinal canal. So we said it is an oblique cleft in the lower part of the anterior abdominal wall, an oblique intramuscular cleft in the lower part of the anterior abdominal wall, at the lower part here, commencing at the deep ring, which is a circular defect in the aponeurosis of the external oblique, and the superficial, and ending at the superficial ring, which is a triangular opening in the aponeurosis of the external oblique. All right. Now the canal, we said, is oblique and directed IMF inferiorly, medially, and forwards, 4 centimeters long, and it has an anterior wall, a posterior wall, a floor, and a roof.
Good day, sir. Good morning, sir.
Morning.
Hi, sir. I'm just letting you know that it is 9 o'clock, so we're going to the other class.
Perfect. Okay, so I'm just going to continue recording here, right?
No problem.
So you'll then access the lecture later, all right? Okay. And students, are you there?
Yes, sir.
Yes.
Yeah, I just wanted to tell you that I especially came very early. I came early this morning, you know. But as I said, they were having a lot of technical difficulties in putting up the lecture. Okay, so I really had to try to start on time. But I can give you a little joke. Hear the little joke I must give you. That last night I was preparing for my lecture this morning. Okay. No, what lecture do you think I spent till about 2 o'clock this morning going over my slides and fixing them up and this and that? And the lecture that I was getting ready for this morning was the brachial plexus. Can you imagine the brachial plexus? And just when I was going to my bed now, at about 2 in the morning or so, I said, oh my gosh, but I'm not lecturing on the brachial plexus. I'm lecturing on the what? Inguinal and femoral. So I quickly had to go to my PC and get it on and you know, get things organized. So that's quite a story. But I had to laugh that I was getting ready for the brachial plexus, which is for a lecture I have for the junior students. All right. All right, guys. So I will continue recording, and then now what we want to do is to see if I can now give you an extra lab of about an hour when I'll be doing now inguinal canal. Okay? All right. Enjoy your day.
Thank you, sir.
All right. Take care. I'm going to continue with my.
Sir.
All right. I'm just going to continue with my recording here. Okay. So we're looking here now at a dissection. Okay. So they've removed the external oblique. And by the way, these you will see are these 5 folds. Look, very interesting. This is a nice thing to show you the 5 folds that we were discussing yesterday, right? And there is the midline one, which is the obliterated urachus. There you can see the obliterated urachus. Lateral to this, we see the medial umbilical ligament. So this is the median formed by the obliterated urachus. This is the medial formed by the umbilical artery, and this is a lateral which is formed by the inferior epigastric vessels. So what they've really done is to dissect off everything, sorry, and show you here the deep inguinal ring with the structures entering into the spermatic cord. Okay. All right. Okay. Okay, so this is a nice dissection here. So there we can see a lovely dissection. So that's the spermatic cord now. And there you can see the spermatic cord going down into the scrotum. Okay, beautiful. They have dissected off the external oblique aponeurosis. So they've just cut it at the inguinal ligament. See, they've cut along the inguinal ligament, and they have a bit of the internal oblique here. A bit of an internal oblique and the transversus abdominis. Okay, okay. So we're looking at now at the inguinal ligament, and we're looking from behind here, and we can see where this inguinal ligament is going to continue as a locumlar ligament. And the locumlar ligament is going to continue along the pecten pubis as the pectineal ligament. Okay? And therefore, that's now going to give us now the femoral ring. Okay? Remember, we're discussing that in the lab, and we're looking at the femoral ring. So here we're seeing the femoral ring. So that's the inguinal ligament coming down, spinning around as a locumlar ligament that has a sharp free crescentic border, and there we're going to see the pectinal ligament. And above this, and I showed you yesterday in the dissected specimen, there is a deep ring. All right, and in the one that I showed you yesterday, it was a female, and we actually saw where the round ligament was entering. Okay, so that's a deep ring, and we notice that medial to the deep ring is the inferior epigastric vessels, which are coming off the external iliac vessels. Okay. All right. Okay. So there we can see some little notes on the locumlar ligament. It's triangular in shape. The lateral border is curved and forms the medial border of the femoral ring. Okay. A fibrous band extends along from it, and this is referred to as a pectinal ligament, and the pectinal ligament of Astley Cooper. Okay. And the pectinal ligament of Astley Cooper. I just want to say that his name is very significant, Astley Cooper. You're going to encounter a lot of names in anatomy, but his name really stands out way, way above the rest, because Astley Cooper was maybe really one of the top surgical anatomists in the world, you know. He was really a brilliant, brilliant man, and he is really connected very much with his work that he did on the breast. So the breast is now held in place by what I refer to as the suspensory ligaments of Cooper. Okay? So there you can see the locumlar ligament now forms the medial border of the femoral ring. Okay? So this really is a very good diagram that we're looking at right here. And we can see the vas deferens coming in, right? And there will be about 3 arteries that are entering, and there are a lot of veins, okay? Right. So the external oblique, there we can see it right here. Okay. So they're just reviewing the external oblique. All right. Reviewing the external oblique. Transversus abdominis. Okay. Transversus abdominis there. Now, just to see that the, okay, just to say now that the internal oblique, remember that the internal oblique is going to arise also from the lateral 2/3 of the inguinal ligament, right? The internal oblique is going to arise now from the lateral 2/3 of the inguinal ligament. And is going to go over the spermatic cord, meeting the transversus abdominis, meets the transversus abdominis to form what is referred to as a conjoint tendon. Okay? Right? So the insertion. So when that internal oblique goes over, arches over to roof over the spermatic cord, it's going to join with the internal oblique, is going to join the transversus abdominis to form a very important structure called the conjoint tendon. And that conjoint tendon, also known as the falx inguinalis, is going to insert into the pubic crest and the pectinal line, or pecten pubis. So the conjoint tendon, and that conjoint tendon is very, very important because it's going to strengthen the posterior wall of the inguinal canal medially, and it's going to help to prevent a direct hernia. Okay, so the conjoint tendon is a strengthening structure. I'll show you in the lab what it looks like. Okay, so the internal oblique, when it arches over the spermatic cord, is going to meet some fibers of the transversus abdominis to form what's called the conjoint tendon, or the falx inguinalis. And that's going to insert into the pubic crest and the pectinal line. Okay? Now remember the transversalis fascia. Just to say that that transversalis fascia will form the posterior wall of the inguinal canal. Okay, and there you can see a bit of the transversalis fascia right here. So it's deep to the transversus abdominis, and it's going to form the posterior wall of the inguinal canal. We'll see that later. All right. Okay, so this is a very nice diagram right here. And we see the deep inguinal ring, which is occurring at the midpoint of the inguinal ligament. There you can see directly above the midpoint. So we can figure it like a tube, like the tube I brought into the lab yesterday. And it has a triangular opening called the superficial inguinal ring. And there you can see transmitting the spermatic cord. All right, so this is very, very important. Okay, now this is a beautiful dissection. Wow. So there we see a really lovely dissection right here. Okay. And there we can see the spermatic cord. There's a nerve that sort of quickly passes through, which is called the ilioinguinal nerve. That ilioinguinal nerve will exit through the superficial inguinal ring, the ilioinguinal nerve. But there's a spermatic cord coming down, and there we can see the testis, and the spermatic cord has its various coverings, okay, right? And there, this is now outlining where the inguinal canal is, okay? And this would be the position of the inferior epigastric artery. This is a beautiful dissection, okay? So you should really try to study and see what's happening here. That's the aponeurosis of the external oblique right here. Clearly you see the aponeurosis that's cut open, all right? And they're showing you where that inguinal canal is, and that the spermatic cord is traveling through, and that the internal oblique is roofing it. All right, a lovely dissection. Okay, see a little bit more of it here, and that is the inferior epigastric artery. Wow, so this is really a beauty here. Okay, so it's showing you the spermatic cord as it's traveling through the inguinal canal. So what is happening that the spermatic cord is going to have three coverings. It's going to have a internal spermatic fascia, a cremasteric fascia and muscle, and an external spermatic fascia. Okay, so as the testis is passing through, remember the gubernaculum testis is pulling there, and as the testis is passing through, as it reaches the deep ring, it's going to get a covering of some peritoneum. Okay, that's going to refer to as the tunica vaginalis. Then it's going to encounter the transversalis fascia, and the transversalis fascia is going to form what's referred to as the internal spermatic fascia. Then when it goes under cover of the internal oblique, it's going to get another layer called the cremasteric fascia and muscle, and then when it exits through the superficial inguinal ring, it's going to get what's referred to as the external spermatic fascia. So the spermatic cord will have three coverings: an internal spermatic fascia, a cremasteric fascia and muscle, and an external spermatic fascia. Okay? Remember that the peritoneum is going to obliterate. So we'll see a little fibrous remnant, in the spermatic cord. And that fibrous remnant is going to be referred to as the obliterated processus vaginalis. As the obliterated processus vaginalis. Okay? So when the testis is, imagine this ball now just passing through. As it reaches a deep ring, it's going to take a covering, and that's going to be referred to as the internal spermatic fascia that's derived from the transversalis fascia. Then it's going to go under the internal oblique, where it will take off a sleeve of fascia and muscle that we refer to as the cremasteric fascia and muscle. And then now as it's exiting through the superficial inguinal ring, it will take the external spermatic fascia, which is formed by the aponeurosis of the external oblique. Okay. All right. So remember now what contributes to the various walls. Okay. So the anterior wall is formed by the aponeurosis of the external oblique. So the anterior wall of the inguinal canal is formed by the aponeurosis of the external oblique and reinforced laterally by the internal oblique. So The anterior wall is formed by the aponeurosis of the external oblique and reinforced medially by the internal oblique. The posterior wall is formed by the transversalis fascia and reinforced medially by the conjoint tendon. The roof of the canal is formed by the arching fibers of the internal oblique, and the floor is formed by the inguinal ligament. Okay? All right, so those are some very important things. See, that's the spermatic cord, and we'll see that it's roofed by the internal oblique. All right. Okay. So there we're coming to some definitions. An inguinal canal as an intermuscular slit, right, in the lower part of the anterior abdominal wall. It's about 4 centimeters long, can vary between 3 to 5 centimeters long. Runs in an inferior medial direction, IMF, inferiorly, medially, and forwards. Lies parallel and just superior to the medial half of the inguinal ligament. The main occupant is spermatic cord in the males, round ligament of the uterus in the females. Okay, very important. Okay. Boundaries has an opening at each end, deep inguinal ring, which is a defect in the transversalis fascia, superficial inguinal ring, a triangular opening in the external oblique aponeurosis. It also has 2 walls, anterior and posterior, a roof and a floor. Contents of the canal, okay, and we did the coverings, okay. All right. The exit from the inguinal canal is through which the contents emerge, right? A triangular slit-like opening in the fibers of the external oblique, okay. Now, has 2 crura, okay. So just to say that the opening has what I refer to as crura. So it really is a triangular opening with a medial or superior crus and an inferior lateral crus, and is bridged by what are called the intercrural fibers. So that apex is a bit obliterated by what I refer to as the intercrural fibers. Okay. All right. Okay. So the inner opening of the canal found about, now we go a little further, 1.25. So we can say 1.5. Some books say 1.25 centimeters superior to the midpoint of the inguinal ligament. An oval opening in the transversalis fascia. Okay. All right. Well, we won't worry too much about that. The medial aspect of the deep ring may have, right, a musculofascial. Okay, we'll just leave that alone. All right. Anterior wall is formed mainly by the aponeurosis of the external oblique, laterally reinforced by the internal oblique. Okay. All right. So the students, I should just tell you that this lecture that I'm presenting here this morning is a combination of an original PowerPoint by my good colleague, Dr. Laws, and then I added also extra material to it. So it's a combined lecture. All right. So I took over that lecture from him when he left, and so he has given me permission. So I've added things to it. So it's a combined lecture of Dr. Laws and myself. All right. But he is the main author. Okay. So the posterior wall formed mainly by the transversalis fascia, medially reinforced by the conjoint tendon. All right. Okay. Iliopubic tract is a thickening of the transversalis fascia that runs parallel and posterior to the deep to the inguinal ligament. Okay. We don't usually ask about that. Roof. No, okay, so the roof now here is formed mainly by the arching. So exclude the transversus abdominis. I'm going to take this out. So the roof is just basically formed by the arching fibers of the internal oblique. because the transversus abdominis is too far lateral. So it's basically just the arching fibers of the internal oblique. Okay, so that's a nice diagram right there. Okay, the floor. Okay. So we see that the inguinal canal is a site of potential weakness, right? Okay, so, but there are certain mechanisms that strengthen it. And failure of the integrity may end up with hernias. Hernia is a protrusion of an internal organ through a defect or wall of a body cavity, okay? So hernias are very, very, very common. So in Jamaicans, a lot of Jamaican males, a lot end up with hernias. And sometimes there is like a 2-year waiting list to get a femoral inguinal hernia repair, okay? All right, okay, so I think, okay, so we see that there are various mechanisms to prevent hernia. And one is the obliquity of the canal, makes it very valvular. Okay, that the weakest part of the posterior wall, that's where the deep ring is, has the strongest part of the anterior wall in front of it. That's where we find the internal oblique. Conversely, the weakest part of the anterior wall, that's where the superficial ring is, behind it, posterior to it, is the strongest part of the posterior wall. And that's where we get the conjoint tendon. Okay, so there's some other things. There's what's referred to as a shutter mechanism device. So the arching fibers of the internal oblique go over the spermatic cord, and they also will, when the anterior abdominal wall contracts, it will bear down on the spermatic cord. Okay. All right, so we have a lot of information here on the spermatic cord. Okay. So the spermatic cord, let's say something about the spermatic cord. Okay. All right, so there you can see the spermatic cord here, and what immediately stands out to you is all of these veins. Okay. So what really stands out to you is that there are a lot of veins there, and these are referred to as a pampiniform plexus of veins. Okay, so draining the testis now are what are called the pampiniform plexus of veins, and they form a cooling system. So for what's called countercurrent. So as the hot blood is coming down, it meets the cooler blood coming up, right? So we want to keep the testis cool, okay? So the vas is there. There are 3 arteries in there, and there are lymphatics. The lymphatics of the testis are going to drain to para-aortic nodes, okay? Then we will see now that along the way here, we will see that there's a cremaster muscle. So if you stroke the inner aspect of the little boy of his thigh, you'll see the testis is retracted, okay? All right, so the spermatic cord suspends the testis, begins at the deep ring, ends in the scrotum. The posterior border of the scrotum contains structures running to and from the testis. During development, the testis descends from within the abdominal cavity through there. Okay, so you can see all about the descent. And we talked about the coverings. All right, we mentioned where all the coverings are from, right? That the internal spermatic fascia is from the aponeurosis of the transversalis fascia, that the cremasteric fascia and muscle are coming from the internal oblique, and the external spermatic fascia is coming from the aponeurosis of the external oblique. Okay, all of these things are here. Okay, it's so a lot of diagrams here, so you can go through a lot of these diagrams here. You see that the testis has the tunica vaginalis around it that we speak about, that's coming from the peritoneum, right? Now, let me just point out that there are 3 arteries that are in the spermatic cord, and these arteries are always asked about in the exam. 3 arteries. There is what is referred to as a testicular artery, that's coming from the abdominal aorta. There's a cremasteric artery that's coming from the inferior epigastric artery, and there is an artery called the vesiculo-differential artery. And that vesiculo-differential artery is coming from either the superior vesical artery or the inferior vesical artery. So 3 arteries are found in the spermatic cord. The testicular, which is coming from the abdominal aorta. Also in there is a cremasteric from the inferior epigastric, and also the vesicular differential from the superior, the inferior vesicle. Okay. All right. Yes, we talked a little about the cremasteric. And there we see the veins, okay? So there we see the arteries right here. These are the arteries here. So the content of the spermatic, the ductus deferens, the processus, this should really be the obliterated processus vaginalis, the arteries, testicular from the aorta, artery to the ductus deferens, yeah, from the superior and inferior vesicle, cremasteric from the inferior vesicle, veins, pampiniform veins, lymphatics. The lymphatics drains mainly to para-aortic nodes. And the nerve, genital branch of genitofemoral. Remember, we're doing in the lab yesterday, and we said the genitofemoral nerve has root values L1, L2, but it should really be named the femorogenital. So the femoral is L1, and the genital has L2. And there's sympathetics there also that are vasomotor. But that pampiniform plexus is very important. So very, very important. Remember, at the beginning of the lecture, I told you that if this becomes engorged, these veins become engorged, we refer to that sometimes clinicians as a varicocele, and has the feel of the bag of worms. Okay? What should I point out now? Very important, I want to point out that the lymphatics, yes, so the lymphatics, so that's the testis. Sometimes we get cancer of the testis, which is a bad story. Okay? Why it's so bad is just like the ovaries. Women tend not to, does a woman really examine her ovaries, right? The only way she really can properly examine them is when she's doing an ultrasound, a transvaginal ultrasound. And then sometimes you may encounter that there are some pathologies developing. Sadly for the women, when they find out that there's cancer of the ovaries, usually too late, okay? Not all cases, but sometimes things have really progressed because you don't know that it's developing. Similarly, the male tends not to go examining his testis. Okay, so it's a rare thing for the male to examine his testis to see if there are any lumps there, but it happens. So one of my colleagues who is a physician just went for a routine exam, and they were examining his testis to find out that he had cancer of the testis. Oh my gosh, it was quite a story. Okay, so as I said, you have to be very, very, very careful. Okay. And the ductus deferens is a muscular tube, 45 centimeters long, quite long, conveys sperm from the epididymis to the ejaculatory ducts. All right, so there you can see it right here. All right. Okay. The processus vaginalis. We see that the processus vaginalis has a parietal layer and a visceral layer. Okay, and it's in between this space that we may get a collection of fluid called a hydrocele. Okay, all right, so we continue. All right. Okay, now just to point out about the testicular veins, on the right they're short and drain into the IVC. On the left they're longer, 80 centimeters long, and drain all the way up to the left renal vein. So on the left side, it's a longer course going up to the left renal vein. On the right, it goes to the IVC. This is the one that usually gives problems, and we end up with a varicocele. Okay? Remember, there's a round ligament. So the round ligament in the female, one of the supports of the uterus, as you saw in the lab, it was flattened. It's like a flattened band, 10 to 12 centimeters long. and extends from the junction of the uterus to the uterine tube, through the inguinal canal to the skin of the, passes through the inguinal canal and goes into the skin of the labia majora. Okay, or the round ligament. Okay, so the canal, okay, give a chance here. All right, so some nerves in that region. All right, so students, what I'm going to do is in the next in the lab. So I have some things here now on the. Let me just go through, skip through, because time is running out. They just came a while ago. So, my time here, so you can go through. There are a lot of other extra. There's quite a bit of good information here. We go through. Femoral canal, remember, is a medial compartment in the femoral sheath, right? So we said a little about it. So I'm going to deal with that in the, if I get some extra time to do a little lab with you. So there you can see the femoral hernia. So remember that femoral canal is a medial compartment of the femoral sheath. So the femoral hernia is usually inferior lateral to the pubic tubercle. So when you palpate the pubic tubercle and go a little inferior lateral to that, we will see the femoral canal, okay? And that's through where we may get a femoral hernia, okay? All right. So they're beautiful. So there we can see it here. So this is the femoral sheath. Remember, the anterior part of the femoral sheath is going to be formed by the transversalis fascia, and the posterior part is by the fascia iliaca. So it's the medial compartment, commences at the femoral ring, which we have discussed a lot about yesterday, right? And in there, we're going to find the deep inguinal node of Cloquet. Okay, there we can see the beautiful right here. So that's the femoral canal right here. So this is going to be a continuation of the transversalis fascia, and that's the fascia iliaca below here. Okay, and beautiful, there's the inguinal ligament right above. So this is a very nice slide. Okay. All right, and the femoral sheath. Okay, femoral vessels passing there. Transversalis fascia anteriorly, fascia iliaca posteriorly, proximally wider, distally tapered, and ends fusing with the vascular adventitia. This is saying 3 centimeters, but sometimes usually more 4 centimeters. Okay, all right, the lateral wall is pierced by the femoral branch of the genitofemoral nerve. Okay, genital branch. Medial wall is pierced by the okay. So there we see femoral sheath, okay, and the femoral ring. All right, students, I'm going to end off here now. Running a little late, so, and the rest of the PowerPoint is there for you. So I'm going to ask somebody to shut this down for me, okay?